Today we're joined by Dr. Kevin Fung, who's a pediatric interventional radiologist at Hong Kong Children's Hospital, the tertiary centre for complex pediatric cases in Hong Kong.
Thank you very much, Dan, and thank you for inviting me to give this talk. So I'm just going to give an overview of what we do as pediatric IRs. So I often get this question when I meet my friends or my parents. So what's a peds interventional radiologist? So that's what most people in Hong Kong think I do. They think I'm the radiographer to position kids to take images. My parents are a bit better. They think I look at x-rays and, make diagnoses with my friends. And my classmates think that I normally have a cup of coffee and just sit in the reading room and do nothing. And my patients know a bit better. They think that I'm a clown, basically. And this is what I think I do, high-end, advanced interventional stuff. But mostly actually what we do as IRs or peds IRs, it's lots of time we're on the phone, we're talking to clinicians, we're talking to our nurses, or we're talking to parents. There's a lot of communication, but it's fun. So a short glimpse of what we do as a peds IR. This is mostly what we enjoy doing, which are procedures. So this is a cryoablation of a kidney. And we get to see a lot of patients in the wards, and that's actually a very rewarding part of being a peds IR. So this is me going up to the ward to teach the nurses how to access a hemodialysis circuit in the kid. And we do a lot of procedures with anaesthetists, and that requires a lot of planning. So this is part of peds IR as well. Compared to adult IR, we do a lot more planning, pre-procedural planning, and we have to communicate with the anaesthetic team and do a lot of pre-IR huddles. And this is actually a real life case where we did an intrahepatic lymphangiogram, and we have to transport the patient under general anesthesia to the MR suite. So good communication is the key to make sure the patient and the procedure is done safely. And of course, MDTs, I'm sure you guys are all familiar with that, and IRs play a huge role in the management and the discussion of MDTs. And of course, peds IR are fun-loving people, and this is one of our Christmas gathering in the IR suite. So this is my hospital. I'm from Hong Kong, and our hospital just started operating in 2019, and this is where you can find us in the old Kai Tak airport. This airport's been demolished now, and this is the classic scene of a plane landing in the old airport. So we're basically at the oil terminus of the old airport, and we are the tertiary center for all the oncology cases, renal nephrology cases, complex cardiac cases, and we do all the transplants in this hospital. So this is our radiology department. A peds radiology department is obviously fun, and we have a hybrid theater, and we also have a biplane angio suite inside our in our department. The good thing in our department is that we are joint diagnostic and interventional radiology, so we can use the MR machines and their CT machines for procedures without resorting to begging people to let us use their machines. So the life of the peds IR is a bit different from an adult IR. You can see from our caseload, we do a lot more lines, we do a lot more biopsies, but there are also fun stuffs. We do a lot of vascular anomalies. That's quite rare in adult. And we do some renal angioplasties as well as lymphatic imaging and interventions. So what's so special in doing IR in children, and what do we have to be careful or be beware of? This is a really old saying: children are not little adults, and often we have to put in drips or lines for really tiny baby, which is the size of my forearm, basically. But it's not always true. Perhaps right after this patient, I'll get this patient who's probably a teenager, and she couldn't even possibly lie on the CT gantry safely. So it's a huge range of patients in both age and sizes, and it's really challenging, and it's part of the fun of peds IR. So these 4 areas are how children are special. So firstly, they need sedation. Most of them need sedation, some form of sedation. They get quite scared when they get into the IR room, and you want them to calm down so that you can do the procedure safely. And often we have to work with anaesthetist as a sedation provider and sometimes pediatrician. So we have to balance this triangle. So it has to be safe, and the patient would have to be at an adequate conscious level, and he or she would have to be comfortable to undergo the procedure. So the anaesthetists use all kinds of, great medicine, propofol, fentanyl, and Precedex. But the key is to communicate with them to let them know at which point your procedure is going to cause significant pain, and they can up the level of the medication at the right point. And I always emphasize that using a good local wins half the battle, because once you anesthetize the patient well using local anesthetic, then the anesthetist can lower their intravenous medication level and will improve the patient's safety outcome. So this is how I inject the LA. Usually I infiltrate the skin first to numb the skin so that the patient is less irritable, and then I will anesthetize the rest of the subcutaneous tissue. And using EMLA is always a good idea if you're going to poke the kid. Put the EMLA on, let it leave for 30 minutes, and that would numb the skin right away. And it's always very important to note the LA dosage, the local anesthetic dosage, when you're dealing with kids, because they do reach their max dosage quite quickly, especially in small kids. So this board is what we use in our department to make sure that we don't exceed the saved maximum dosage. And in Peds IR, it's very interesting. In adult hospital, usually you do a diagnostic scan somewhere and then the patient comes to you. But in a children's hospital, usually we do something called one-stop service. So for example, if a child presents with a tumor, then you do the diagnostic imaging, the staging, the biopsy, the line, and even the bone marrow biopsy all in one go under one sedation. That minimizes the patient's number of sedation. It gets the diagnosis early and they can start treatment early. So this is part of the fun of it, I guess. The second part is radiation dose. I'm sure you realize that radiation has a stochastic effect on children, and they may cause cancer. So there's this scheme where we say step lightly and be careful. When you do fluoroscopy, we follow the ALARA principle in that we use as little radiation as possible, and we child size the technique, meaning that sometimes we remove the anti-scatter grid on the fluoroscopy machine to reduce the dose. And think ultrasound, or well, MR is more advanced, but think ultrasound. Ultrasound is actually a superb tool to have a cross-sectional view of the organs in children because they're so small. The ultrasound beams penetrate really well. So there's a variety of ultrasound probes. Know your ultrasound well. If you can do the ultrasound well, you have already won half the battle already. So I'm going to show you a case. So this case is a case of biopsy of a 16-year-old girl with an incidental superior mediastinal lesion, and this is the CT. If you want to have image guidance during biopsy, ultrasound in this case is much better. I mean, this lesion is straddling between the left common carotid, the brachiocephalic artery. If you do it under CT, you don't have real-time guidance. You don't know where your needle is going. If you're using ultrasound, if you get your acoustic window really well, you can see your needle, where your needle's going, and that makes it a really safe way to do the procedure. And contrast volume and fluid status is also a very important point, especially in small children. In a very young child, the main risk is nephrotoxicity, and then of course you can get allergic reaction. So there are certain risk factors in patients that would increase this, but in children, the weight is one of the main issues. If you have a very small child, very young child, their kidney functions have not been fully developed yet. So using contrast, we need to limit the dose to limit the nephrotoxicity. So how much is too much? So for a neonate, for example, we're taking 4 to 5 mils per kilo, and a normal neonate is like 2 kilos. So if you're doing an angiogram on a kid, 1 10 ml syringe would already be your total dosage. So what we do is we can dilute the contrast. We can do 1-1 dilution to try to increase the volume of contrast that we can use. But the thing is, for example, for a 2 kilogram neonate, the total blood volume is actually only about 120 mil. That's half a can of soda here. That's 1 can is 330, and it's only half a can of soda. So if you lose 10% of blood volume, or if you inject 20 mil of contrast, that's already about 20% of the blood volume. So that's quite significant for a small child. So I'm going to go through 5 areas for this talk because there's just so much to go through. So I'm going to choose 5 of my favorite, and I'm going to go through it with you guys. So the first thing is biopsy. Boring, but it's essential. And if you do it well, your pediatricians will love you, your pediatric oncologist will love you, and the children will love you because you don't have to subject them to another biopsy. So what do we most commonly biopsy? So we have the focal lesions. So we have the solid tumors, neuroblastoma, hepatoblastoma, lymphoma, and then we also have the bone and soft tissue lesions. And then on the other hand, we have the non-focal lesion biopsy, liver, kidney, to get the parenchyma for a parenchymal diagnosis. So for focal lesions, for kids, we try to obtain as many cores as possible. And up to, when I was trained as an adult IR, I thought 3 cores was already a lot. But when I went into peds, they really test for a lot of things. They test for the molecular profile, they test for the genetic profile, and that all requires tissue. And you remember your competitor is a pediatric surgeon who can excise as much tumor as they like as possible. So we have to be as good as the pediatric surgeon in getting as much core as possible so that the pathologist can make the correct diagnosis and they can do all the genomic and molecular profiling, which can then tailor the treatment for the child. So I always use coaxial biopsy. If you haven't seen this before, this is the coaxial cannula and this is the biopsy needle. So don't assume that just because we're biopsying small patients, we're using small needles. In fact, I commonly use 18 or even 16 gauge for deep lesions. So for neuroblastoma, for example. And for superficial lesions, I use even larger gauge size because I can manually compress and stop hemostasis. And for bone lesions, I would use even bigger cores to try to get the biggest bite as possible. So this is what happens in coaxial technique, if you haven't seen it before. So the coaxial cannula is inserted into the tumor, and then you remove the inner stellate, and then you insert the biopsy needle inside the cannula. You grab your biopsy, and then you repeat the procedure until you're happy with the number of cores. So the good thing with coaxial is, A, you can do as many cores as possible with one single capsular puncture. Secondly, you can embolize the tract with gel foam slurry. So there's 2 ways to do it. Some people like to insert this gel foam torpedo in the stellate, and some people like to use the slurry. I prefer the slurry personally. So this is a case of using gel foam embolization using the slurry. You can see that we inserted the 18 gauge biopsy needle for biopsying this liver tumor. And then once we removed the needle, we injected the gel foam inside the tract and completely occlude the tract. So that stops any bleeding if there's going to be any. So this is the bone biopsy drill that we use. We use it mainly for sclerotic lesions, actually. When the bone is really tough and hard to get through, this drill is a lifesaver. Now, there are even more special needles. I use this needle if I have to reach for really difficult places. So I'm going to show you a video of this needle. So this is called the Ganji Soft Guard needle. So it's got a spring-loaded stellate. And when you actually push it against something, if you're holding onto the stellate, the blunt tip can be deployed and you can dissect through tissues and not hurt it during the process. So for example, in this case, when you're trying to go to a very deep lesion next to the colon and the vessels. So when you try to pass the Ganji needle, if you hold on to the blunt tip stellate now, because you don't want to injure the colon, you can just dissect all the way along and go to your target, and then release the stellate and use the sharp end of the coaxial needle to enter the lesion, like that. And this is a in vivo test on a pig model. So this is your normal diamond tip needle. What will happen is if you transect the vessel, it will just bleed like that. But if you use a Ganji soft guard, and if you deploy the blunt stellate when you're going across the artery, you would just sort of displace the artery and not really hurt it. So the artery is not really hurt here. You can see it just sort of displaces the vessel nicely. Right, so this is a case in which I chose to use a Ganji needle to try to get to this lesion for biopsy. So this is a 9-year-old girl, and she had a history of medulloblastoma and had chemo-RT, and they found this C12 lesion here. And you can see that this is the internal carotid artery and this is the vertebral artery. So they want to get some tissue. And I was like, oh God. So how are we going to do it? So this is the CT of the lesion, and this is the ultrasound. You can see very well the vertebral artery and the ICA. So we use a Ganji soft guard needle under ultrasound, and we sort of deploy the blunt end in case we hit any arteries. And you can see that the needle actually just goes through the gap of the ICA and the vertebral artery and went into the lesion safely. And the pathology came out to be PVNS, surprisingly. So this is one of our more difficult biopsy cases. So going on, this is a second part of PEDS-IR. That's the bread and butter and super important, is to get access into the veins. Now, it's different from doing an adult line. When I receive a line request, I always study it carefully, and I'll ask myself several questions. So what kind of infusate does the kid need? Does he or she only need a short-term antibiotic course for a few weeks? Or is this going to be, for chemotherapy, hematopoietic stem cell transplant, which means that the kid would need several years of that line? Or even worse, if it's going to be a case of hemophilia or metabolic disease, the need of a line is probably lifelong, or shortcut patients really need the line for lifelong. So think about that. You have the expected duration of the line, and you've got to think about long-term in kids. They're not like adults. I mean, if you put a line in the internal jugular, if you put a long-term line in, that line might be lasting him or her for 10, 20 years easily. So you want to preserve as much vein as possible. Think about which vein you're going to use. And when I first started with vascular access, I always find it overwhelming. It's like going to a supermarket. Everything looks the same, but it's slightly different. So you've got lots of choices. You've got to make the choice of putting in a short or long-term catheter. And then you've got the choice of the PICC versus a central catheter versus ports. And then you've got to choose which vessel to put it in. And you also have to think about, do you want to tunnel the line or do you not want to tunnel the line? The good thing about having a tunnel is that it prevents bloodstream infection more effectively if you dissect a subcutaneous tunnel. So I'm just going to show you a few examples of the catheters if you're not familiar with them already. So we have the temporary lines. This is your most vanilla sort of temporary central, we call it central lines basically. And then you have the temporary hemodialysis catheter. The hemodialysis catheter have larger lumens, you can see that. It usually have a blue lumen for drawing venous blood and a red lumen for pumping in back the hemodialyzed blood into the patient's body. And then for the long-term ones, you've basically got four choices. You've got the PICCs, your peripheral inserted central catheters. You've got your ports. So these ports, the part of the port gets implanted inside the patient's subcutaneous tissue, and you need a special needle to access them. And then you've got the tunnel cuff catheters. So they're tunneled, and there's a cuff in the central venous catheter to prevent the child from tugging it and dislodging the catheter. So fibrous tissue will grow around this cuff, and it will secure the line. And same for the long-term hemodialysis catheter. It's basically a tunnel cuff version of the temporary catheter, and you've got a lot of different end configurations for the catheter end. So there's the split ends, and sometimes you've got the tapered ends. So basically what you'll see two distinct lumens, one for drawing blood and one for pumping it back in. So this is one of the decision support algorithm that I use sometimes if I've got problems to decide which lines to use. It's developed by a group of line expert nurses. So it basically tells you if you've got a certain scenario and you're going to think about if the infusate is peripherally or non-peripherally compatible, and you're going to think about the line duration, and then it sort of suggests what is a good line to use in your situation. Now, choosing the right vein is very important. The number one rule is use the smallest device in the largest vein. So the reason for that is you don't want to occlude the vein and you don't want the vein to thrombose. So for example, for a PICC, I would go first for the basilic vein because it's most superficial and it's usually the largest and most well developed. Secondly, I might go for the cephalic But in small children, you'll see in a minute, the cephalic veins are not well developed. So they undergo spasm easily, and you may have difficult threading your catheter in, even if you can get access. Brachial is deep and it's close to median nerves and brachial artery, so I usually avoid that if I can. And for central venous catheter, I would choose internal jugular first before I go for femoral. The reason being the neck is usually the cleaner vein. So the second thing is you want to choose the right device. So what's the optimal catheter to vein ratio? So basically, the sort of rule of thumb is half. A 3 French catheter is 1 millimeter. So if you have a 2 millimeter vein, the maximum catheter size will be a 3 French catheter. But you also have to take into account what the patient need. So if the patient needs multiple infusate and they want to put in a double lumen line, it's no good putting in a single lumen PICC for them, because obviously they then would need to access another vein to get another line in for the other infusate. And kids' vein, they're difficult, they're small. This is one of the larger veins actually, 2 millimeters. They get difficult to puncture when they get less than 2 millimeters because they sort of float around. Choose your ultrasound probe wisely. I always use a hockey stick because the footprint is small and it sort of has a very high resolution, so you can see everything very clear. You really need a very good ultrasound machine to see where your needle is, see where your vein is. Know your access needles well. Obviously, for different age group, we use different access needles. So this is a 24 gauge angiocatheter, and I use that most commonly for a small children. For veins less than 2 millimeter, a 24 millimeter angiocatheter works like wonders. And you also need to know, with this access needle, what wire you're going to use. So for this, different angiocatheter brands have different wire size, so the inner lumen is different, so the wire combo is different. I would try it out first before I actually try it on the patient, because once you get access, everything happens very quickly and you need to get the right wire in. So sometimes they come in a set. So this is a micropuncture, 4 French micropuncture set, so this comes in a set. But for example, if you're using angiocatheters off the fly, then you really need to try it out. So always have a plan, choose the best looking one, and have another one as backup. Because if one once you puncture it and it starts having you start messing it up and it starts building a perivenous hematoma up, and it gets difficult. So have another vein as backup, and usually work your way up. Because if you blow up the vein up here, and the downstream vein might get affected, and you may have difficulty threading a wire up. So two major ways to do. Always do it under ultrasound, basically. But there's 2 ways to guide it. So you have the longitudinal section, and then you have the transverse section. So the good thing about the longitudinal section is you can estimate how deep your needle is going, and you can visualize your whole needle in one single path. I usually do this for larger veins. I love seeing my needle, my entire needle in plane. But if you look at the intensivists and you look at the anesthetists, they like to do it in the transverse fashion. Well, each has their own benefit. Basically learn both methods and choose a method that you're most comfortable with. So for veins less than 3 millimeters, I would actually use a transverse approach, because the vein, the kid has really soft and bouncy soft tissue. So when you try to insert your needle or puncture the vein actually just slides away. So what I do is I look at the transverse, and then you dart it. You might even double puncture it, and you slightly pull back so that the cannula of the angiocatheter would slide back into the vein, and then you would get backflow, and then you do your wire access. So kiddie veins, like kiddies, they're not fully mature. They like to go into spasm. They're shy, just like kids. So handle them with care, and don't inject too much LA around the vein. Don't inject too much local anesthetic around the vein, because it will cause spasm and it will make your puncture more difficult. So this is another area of big controversy, which is the catheter tip location. The proper location would be at the SVC right atrium junction, and on the X-ray, it would be about 1.5 to 2 vertebral levels below the carina, and that's your perfect level. And for hemodialysis catheter, they need a larger volume for exchange, so they usually put it in the right atrium. So be careful for catheter tips. For PICC, they're actually dynamic. If you put the patient's arm up or down, that can make a big difference. It doesn't make a big difference in an adult because the SVC is so long. But imagine in a 3-year-old or 4-year-old, the SVC is actually only 5 millimeter. So when you're moving the arm up or down, that would already be a 2 centimeter difference. So that makes a huge difference. And if you have a sedated kid in your lab and everything's going well, and when they go back up to the ward because they raise their arm up and the catheter flicks back up, it can cause trouble, and you have to call the patient down again, obviously, to readjust the catheter under anesthesia. No one's going to be happy about that. So special circumstances call for special lines. So for example, in this patient, you can see that the SVC is obstructed. So what we have to do is we have to think out of the box and do a tunnel cuff femoral line instead. This line actually has a similar efficacy as your tunnel neck Hickman's. And as I've mentioned before, this is a cephalic vein puncture. You can see that the cephalic vein is actually very spastic and they go into spasm very easily. Even if you get access, it's difficult to put a wire in. We're lucky in this case, we're able to put a 22 kg leader flex in. So we have different techniques for kids who need larger catheters, because obviously a 22 kg leader flex is a really small lumen, it's just about 2 French. So this is called a single stick tunnel technique. So we use the micropuncture needle and create the subcutaneous tunnel in one single stick. So there's a tunnel here already, and you can see that the catheter exit site is actually below the diaper line, so it's fairly clean. So we can actually do it this way to do a sort of clean femoral line by doing a single stick tunnel technique. And this is even slightly more advanced. So this is single stick neck. But in doing this, you have to curve your micropuncture needle and insert it under the ultrasound in a curved fashion. This is more tricky because you're not visualizing the whole needle in one go. So catheters can malfunction. These are the common reasons. The first one's most scary, catheter breakage, actually. You have to snare that back out. Unsatisfactory tip position, a chest x-ray will usually sort that out. So I'm going to talk about fibrin sheath because you can't see those and people get quite confused about those sometimes. So this is what happens when the catheter gets left behind for too long. The blood has a lot of fibrinogen and it sort of gets stuck onto the catheter. So it creates a sleeve around the catheter. So when you inject, the sleeve actually opens, but when you try to aspirate, the sleeve clamps down on the catheter. So the classic symptom of a fibrin sheath is you can inject, but you can't aspirate. And when you do a linogram, you can see that the contrast just outlines that fibrin sheath coating. And in really bad cases, it would reflux back along the tunnel and you would have contrast seeping back out. So how can we deal with these fibrin sheath? So obviously you can try to lyse them with fibrinolytics, or you can try to strip them with a snare. Basically, you snare the catheter and try to just pull it and try to strip the fibrin sheath away. And you can see that line, the contrast is now flowing to right atrium beautifully. Or you can exchange the line with a sheath and then put an angioplasty balloon in and try to disrupt the fibrin sheath. And again, you can see in this line, this was the fibrin sheath. And then after disruption, the contrast is fanning out much nicer. So moving on, this is going to be third part of this overview. So renovascular hypertension, again, is one of the commonest arterial intervention that we do in children. So fibromuscular dysplasia is one of the most common cause, and it's because of abnormal musculature inside the renal artery. So the treatment will be angioplasty. So you do a balloon angioplasty. When do we do it? It's not totally evidence-based in children, but if we have a child with resistant hypertension, despite going on, all 3 drugs, we try it. Or if the child has a lot of side effects from the drugs, and we will also do renal angioplasty. And the last scenario is if you have a case of bilateral fibromuscular dysplasia or unilateral fibromuscular dysplasia in a single kidney. You want to save that kidney and you want to save the function of the kidney. So what's so special about doing renal angioplasty in children? Obviously, their vessel is small. You can see this is a 5 French guiding catheter, which is about 2.7 millimeters, already occupying your entire renal artery. So the instrument is difficult to get, and you have the contrast dose limitation, small profile device. So we often use coronary devices, adult coronary devices the size is similar to that of a child's kidney. Getting arterial access is difficult, and managing the arterial access afterwards is difficult. Say you have a 2-year-old kid. After you remove the sheath, you want the kid to stay still for 6 hours. No way, they're not going to do it. So sometimes we have femoral casts to keep the child stable for a while, because these childs have to be on heparin as well for a while. So you really don't want the groin to bleed out. And in fibromuscular dysplasia, angioplasty is the way to go. Don't use stents. The kid's vessel will grow, and if you use stent, the stent will be undersized for the child's adult size vessel. So this is angioplasty prior and then after. So you can see we restored that area of occlusion beautifully. So this is another case. This is a case of mid-aortic syndrome with a left arterial renal stenosis here. The problem is, if we go from below, it's very difficult to engage this left renal artery. You can see here the angulation is horrible. So what can we do? So in adults, there's this transradial access FAD, and we did this case under transradial. Actually, we did it via the snuff box approach. So going from above is a much easier way to get across that stenosis, because the angulation is perfect for doing this case, and this is the end result. So you can see with transradial access, after removal of the occlusive device, the wound is actually extremely minimal. So the fourth part is actually, this is my favorite part, and I do quite a lot of this, and this is one of the hot topics in IR at the moment, which is lymphatic imaging and intervention. Kids get a lot of those, but a little bit about lymphatic, if you don't have any background of it. The lymphatic system is often called the forgotten circulation, but actually it has a super important role in maintaining your fluid balance. It's a vital part of your immune system, and when you eat and digest food, all that fatty acid gets absorbed into the lymphatic system first before going back into the venous system. And also the liver, actually, most of the liver protein that's synthesized has to go through the hepatic lymphatic, go through the lymphatic system before getting dumped back to the bloodstream. So that's a super important area. So how do children get conduction abnormality in the central conducting lymphatics? So obstruction is a main one. So how do they get obstruction? So for example, if they have prolonged line access, and if they have occluded bilateral internal jugular veins, that's one of the reasons why they would get lymphatic hypertension. And this kind of lymphatic hypertension would backflow and cause all the abnormal symptoms. So they have chylothorax, they can have classic bronchitis in which they cough up bronchial casts. They can lose the liver protein through the bowel because it's basically a reverse flow. So everything should flow back to the venous system, but in protein-using enteropathy, it just flows back into the bowel. And you can have chylous ascites, and of course you can get lymphedema if you get lymphatic blockage. So the other reasons kids get this kind of abnormality is if they have cardiac surgery, if they have something called a Fontan operation, the venous pressure is extremely high, and that would also cause lymphatic hypertension. And then you can have congenital absence or genetic alteration causing abnormal lymphatic proliferation, and that would cause multi-compartment lymphatic flow disorder. So there are several access points where you can get into the lymphatic system for imaging, for intervention. So remember, there's 3 major compartments. So there's the truncal compartment, so your limbs, and then there's the liver compartment, which is the liver, and then there's the mesenteric compartment. Why is it important? Is because we have to understand the anatomy and the physiology to get to the right point for access. If we want to access the truncal and lymphatics, ultrasound is the best. The inguinal nodes is the best place to do it, and we usually do it under ultrasound guide puncture. And we hook it up with a Lippardal pump, and this is what you're going to see in a Lippardal lymphangiogram. So when do we do truncal access? So if the patient simply has chylothorax or plastic bronchitis, the lymph flow goes up like this. When you're imaging it, you can actually, so for example, in this case, this is just a truncal injection. So you can already image the chylothorax here, and then you can also image the thoracic duct venous angle, where there's obviously lymphangiectasia here. But if you are suspecting chylous ascites, protein-losing enteropathy, or multi-compartmental leaks, you really have to get access from the liver or even the bowel to really to visualize the lymphatic leak from there. And this video will show you why. So if you just access from the truncal region, you will bypass the liver lymphatic and you won't be able to see it. So you really have to put your needle in the liver to visualize how that lymph flow is being dumped into the duodenum. So I'll show you a case here. So if we puncture a needle into the lymphatics in the liver, and if you inject methionine blue, you will actually show up in the duodenum. And that would cause protein-losing enteropathy because remember what I mentioned, 60% of the protein synthesized by the liver is actually transported by the lymphatic system. And this is one of our cases. We punctured the hepatic lymphatic, and you can see that this pattern here is actually the duodenal fold. So this is going down. And if you were just injecting truncal, you would miss this part entirely. So this is a dynamic contrast injection of MR contrast. So when we inject contrast via this needle here, you can see that contrast spills into the duodenum. And of course, it also goes up into the thoracic duct, and there's a huge matter lymphangiectasia here. Why is it important to image it? Because how to intervene depends on the cause. So if it's a simple traumatic chylothorax, thoracic duct embolization will work. You block off that leak physically with coil or glue. If it's a non-traumatic lymphatic flow disorder, then obviously you need to be more selective. You don't want to block the thoracic duct off. If you block it off, then it's going to make things even worse. You can imagine if you try to block this channel off here, then all the lymph would then flow back into the stomach and the bowel as well as the peritoneal cavity. So it will convert a chylothorax into a massive chylocystis. And a lymphatic diversion therapy, so you can do venoplasty if there's venous obstruction, or you can do, well, not you, but the surgeons can do microsurgeries to connect lymphatic channels with venous channel, so-called lymphovenous anastomosis. And if we can identify certain targets, we can use medical therapy to try to reduce the lymphogenesis. So this is thoracic duct embolization, this case from Dr. Itkin. So this is the cisterna chyli, and we basically use a Chiba needle under fluoroscopy to access the cisterna chyli, and then we put a wire in. You can see the leak here, and we use coil and glue to obliterate this segment. This is the basics of thoracic duct embolization. That's what we do. So this is another thing what we can do. If there is a lot of lymphatic leakage from the hepatic system into the duodenum, we can inject glue into the system to try to block off these lymphatic channels and block off the lymphatic leakage into the duodenum. So the last bit of my talk is going to be on embolization. Obviously, arterial embolization, there's a lot of emergent or elective indications for it. For kids, mostly, like adults, we use it to stop acute hemorrhage. We use it to reduce preoperative bleeding. We have chemoembolization for children as well, and we use embolization to arrest high flow situation in certain situations. So there's a lot of weapons. I'm not going to go through them because that deserves a lecture on its own, which embolic to use in what situation. But I'm just going to show you a few examples of what we can do in kids and what we have to worry about. So this is basically a kid version of a rupture HCC. Hepatoblastoma is one of the most common liver tumor in children, and they can rupture. And this is a case of rupture hepatoblastoma. You can see that the bag is full of fresh blood. And this is the angiogram of the left hepatic artery. You can see all these abnormal pseudoaneurysms from the tumor. So we basically used EG gel in this case. EG gel is calibrated gel form particles, so you don't have to pre-cut them. You just mix them with contrast, and you can, and they're bioresorbable. So the arteries can be recanalized in the future if you are going to use chemotherapy. And this is a case of a massive thoracic tumor, and they were planning surgery, and they're really worried about this right bronchial artery here. So what we did is we went in. This is a right bronchial artery injection, and you can see all this tumor vascularity here. So we basically just deployed some coil and EG gel, and you can see that this is the post angiogram. It showed much reduced tumor vascularity, and the surgeons can get the tumor out easily without too much bleeding. And chemoembolization, not just for hepatic tumors. This is a study I joined for desmoid fibromatosis. So desmoid tumor, if you're not familiar with them, they are they are more like fibromatosis. They're not malignant tumor in the sense that they will metastasize, but if you try to remove these tumors surgically, they will recur 100%, even if you get a clear margin. Most often you can't get a clear margin, but even if you can get a clear margin, almost 100%, they will recur and they will become much more aggressive. So they're extremely difficult tumors to treat. There are several ways to treat it. Ablation, cryoablation is one. Chemoembolization is another option if you have a really extensive tumor that is encasing a lot of critical structures. So this is a patient that I treat. He's got this extensive desmoid in the left lower limb here, and you can see after 4 courses of treatment, there is still significant asymmetry, but the tumor volume has shrunk about by half, and you can see all these black area is scarring. It's the tumor scarred down after the chemotherapy. This tumor is encasing the sciatic nerve, so definitely surgery is no go, and it's too extensive, and it's encasing too much structures for using cryotherapy. So this is another case, another challenging case where embolization really can make a difference. This is a 0-day-old neonate, and you can see the heart is massive. If you're not familiar with looking peds X-ray, there's a huge mass here, and there's calcification. And this is the CT, and you can see all these peripherally dilated vascular spaces with a central scar. So essentially, and this is 3D reconstruction, you can see that massive hepatic vein going. So this is a very high flow vascular tumor. This is a congenital hepatic hemangioma. And this is basically a super high flow tumor. And you can imagine all that flow being dumped back into the heart, and it will cause heart failure. And the child will die from heart failure if you don't arrest the flow here quick enough. So what we're going to do is, you can see that because of the high flow situation, the celiac artery is actually massive, but the femoral artery is so small. So how are we going to get inside the femoral artery and get into these celiac arteries for embolization? So this kid has a umbilical venous catheter. If this kid has an umbilical arterial catheter, actually, it would be perfect. We can just swap the umbilical arterial catheter into the aorta and swap it with a sheath, but unfortunately this is not the case. So we've only left with the UVC. So what we did was, this is the umbilical venous catheter, and we basically wired down the right ventricle, the pulmonary artery, and we go through a structure called PDA, which is the ductus arteriosus, if you remember your embryology, and this is where embryology really becomes important. So this patent ductus arteriosus connects the pulmonary artery and the aortic arch in the fetal circulation, and it provides a communication between the venous side and the arterial side. So if we can put a catheter down in here, and we can reach the celiac artery. So this is what we did. So essentially we exchanged the umbilical venous catheter with a 5 French sheath, and we use a 4 French angle catheter to go down this route, so-called the up and over route. So these are the videos. So this is the wire going across the ductus arteriosus here and going down to the aorta. And once we got the wire down, we thread the catheter in and follow the wire down all the way to the celiac artery here. And then we did our angiogram. And you can see this super high flow tumor going into the left hepatic vein. So once we managed to get in, we put in loads of coils, and this is the check angiogram. You can show there's still vascularity, but the aim is not to totally obliterate it. It's just to close off the larger shunt so that the child's heart is not under so much pressure. And you can see on day 2 already the heart size has shrunk almost by half. And this kid is finally she survived actually. So that shows you how embolization can really be a life-saving measures in these scenarios. What I've shown you was only a tip of the iceberg of what we do as PEDS IR. If you're a CERSI member, you can go to CERSI Library. There's a really nice PEDS IR package, and you can see, I've only covered venous access, and there's so much more in PEDS IR that we do and we can do. So please do have a look at this. And if you want to join PEDS IR, there's a lot of, I'm sure in UK there's BSIR, and they have a PEDS IR interest group, and they have, I think this year is the first year that they have an annual scientific meeting, which is great. And also, there's the SPIR, which is Society of Pediatric Interventional Radiology, and they have their annual meeting usually 1 year in the US and 1 year in Europe. And this is a great way. This is actually how I met most of my PEDS-IR friends, because there's not many people doing PEDS-IR in Hong Kong. It's a great way to meet people and learn about new stuff. And if you want to come to Hong Kong to join us and see for yourself what PEDS-IR is about, you're more than welcome. And we have a great program. We welcome serviceship and attachments. You can contact me via here. Of course, in UK, there's a lot of opportunity as well. There's the Great Ormond Street, and there's Leeds Children's, there's Birmingham Children's, and so if you have any questions about PEDS-IR, you're very welcome to contact me. Thank you.
Thank you so much, Dr. Fung. Just a couple of questions. So you've already made sort of a compelling case for why PEDS-IR is so interesting and sort of your day-to-day job is so interesting. But just to summarize, why would you encourage people to pursue a career in PEDS-IR? And if you could just touch on your journey to becoming a PEDS-IR, was it something that you'd been set on from early on in your radiology training? And how did you reach that point?
That's very interesting. So actually, I started off as a pediatric radiologist, and I did a bit of adult IR training. And because we don't have a formal PEDS-IR program in Hong Kong, so my background is that I trained as a pediatric radiologist. But when I did adult IR, I actually found that super interesting. So when I joined this new hospital, the Hong Kong Children's Hospital, I decided that I want to start a PEDS-IR program because there's no such thing in Hong Kong at the moment. So our hospital is the only hospital providing a comprehensive PEDS-IR service. There are actually several ways people join PEDS-IR. You can do it via what I did, which is the pediatric radiology way. Because the PEDS disease spectrum is so different, and you really have to have that, you really have to like kids to like PEDS-IR. It's a lot more patient contact, I find, compared to adult IR. And it's great. You get to see the patients. And you know the neonatal embolization case I showed you? The case has been staying in the NICU for several months. And when I first did the case, the baby was really hydropic, edematous. And one day when I was doing ultrasound round, I was doing my diagnostic round in the NICU, a patient, a parent sort of tapped my back and says, "Oh, say hello to this doctor." I'm like, "Who's that?" And then she's like, "Oh, don't you remember me? I'm the neonate that you did the embolization on." I'm like, "Oh my God." And she looks totally well and totally different. And that's what's so fun, and it really brings joy to your heart when you see cases like that. So that's what PEDS-IR is to me in my heart.
That's great. Another question, do you find it nerve-wracking performing procedures on such small patients? And how do you get over that?
Well, you can say it's part of the fun, but yes, for sure. What I find very helpful is rehearsing the case and doing all the huddles, because usually when we do, complex cases like this, we always have to involve the anaesthetist. And sometimes, for example, with the neonatal embolization, we involve the cardiologist as well. They helped us go across the ductus arteriosus. And it's always helpful to have platform to talk about complex cases with. So I find SPR extremely helpful. They have these online forums, and there are a lot of experienced PEDS-IR there. I often throw my questions up there because it's nice to talk to people about cases and bounce ideas off each other. But rehearsing the case is very important, and making sure your contingency and backup plans are in place in case things go wrong. Yeah, try not to freak out and have a backup plan in place. But yeah, usually after those cases, my shirt under the lead apron is usually quite wet.
And finally, just are there any sort of big developments in PEDS-IR that we can look forward to in the near future? You spoke a lot about sort of lymphatic work, and that's really exciting. What kind of other things are in the pipeline?
Yeah, I think lymphatic is coming along. One huge portion that I haven't touched on in this talk is vascular anomalies, and that is actually a majority of our practice as well. So that deserves a talk on its own because it's so complex. But PEDS-IR makes a huge difference in vascular anomaly, and there's always new therapeutics getting out. So, for example, for arteriovenous malformations in the peripheral system, before we rely a lot on embolization to try to eliminate the nidus, to try to eliminate that hypho component. But now we're bringing out bleomycin, which is a chemotherapeutic agent, but actually it has a lot of, we don't actually quite know how it works yet, but it reduces the vascularity of arteriovenous malformation a lot, and it's a much low risk procedure. So, and then there's electrobleomycin therapy, in which they try to mix electric current with bleomycin to augment this effect. So these are some of the new toys, you can say, that we have in PEDS-IR that can quite make a difference.
That's great. That's really exciting. Brilliant. So thank you once again for joining us. We really
No
appreciate it. And
problem.
so it was a really inspiring talk.